A 2-week-old girl is brought to the emergency department because of poor feeding and lethargy for the past 2 days. The patient was born with ambiguous genitalia but normal female reproductive organs. Physical examination reveals bradycardia and a slightly depressed anterior fontanelle. Laboratory results reveal hyponatremia, hyperkalemia, and increased renin and 17-OH progesterone. A defect in steroid hormone synthesis is suspected. Which of the following compounds normally functions as a cofactor in the reaction affected by this patient's condition? So go ahead and pause the video and try the question yourself before we go into the solution. The very first thing that we have to understand is congenital adrenal hyperplasias. On top of the kidney lies a gland called the adrenal gland, and the adrenal gland is responsible for producing different types of steroid hormones, all from the same precursor of cholesterol. There are 3 layers of the adrenal gland that we should be aware of. Rather, there are 3 layers of the adrenal cortex we should be aware of. The zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona glomerulosa converts cholesterol into aldosterone. The zona fasciculata converts cholesterol into cortisone. And the zona reticularis converts cholesterol into sex hormones. So DHEA, androstenedione, testosterone. And testosterone and androstenedione can be converted into estrone and estradiol, respectively. So now that we understand exactly what we're looking at, there are 3 main enzymes that we should be paying attention to. 17-alpha hydroxylase, 21 hydroxylase, and 11 beta hydroxylase. This chart can get really confusing, but if we remember a couple of things, then we will be able to for sure deduce the exact adrenal enzyme deficiency that our patients are experiencing. So the very first thing we should do is assess androgen status. So the enzyme 17-alpha hydroxylase is required in order to convert cholesterol into sex hormones from the zona reticularis. So after we assess the androgen status and we determine whether or not there is production of hormones in the zona reticularis. Then we have to deduce whether or not there is an elevation in aldosterone or a reduction in aldosterone. So, assuming that there is production of androgens, that leaves us with either 11 beta hydroxylase or 21 hydroxylase deficiency. 11 beta hydroxylase deficiency will present with symptoms similar to producing too much aldosterone. However, the confusing thing is that aldosterone will actually be decreased, but the reason why the patient will present with symptoms similar to having elevated aldosterone is because there will be an increased amount of shunting into the molecule 11-deoxycorticosterone, which is kind of like a budget aldosterone in the sense that it produces the same physiological response as aldosterone. It just simply isn't as strong for the body. If the patient presents with shock and it is neither a 17-alpha hydroxylase or 11-deoxycorticosteroid deficiency, then it must be a 21 hydroxylase deficiency. Additionally, 21 hydroxylase deficiency is the only enzyme deficiency that will have a patient presenting with shock, and that's because there is less aldosterone being produced because of the increased amount of shunting from the 21 hydroxylase deficiency. So now that we understand the congenital adrenal hyperplasias, defunct enzyme synthesis, let's move on to another pathway, which is called the HMP shunt. Remember that glucose 6-phosphate is produced from glycolysis and can further go down through glycolysis to ultimately produce pyruvate. However, glucose 6-phosphate can also undergo what is called the HMP shunt, in which glucose 6-phosphate is converted into ribose 5-phosphate, And in doing so, there is the production of two molecules of NADPH, which are very important in several physiological processes, including the destruction of bacteria in phagolysosomes, as well as the regeneration of glutathione in helping the body deal with toxic metabolites. Additionally, we should pay attention to the enzyme transketolase, which requires a cofactor of B1. And this enzyme catalyzes the conversion of ribose 5-phosphate into fructose 6-phosphate and glyceraldehyde 3-phosphate. The reason why this enzyme is important is because patients with glucose 6-phosphate dehydrogenase deficiency can still produce ribose 5-phosphate from fructose 6-phosphate even if they're deficient in this enzyme. And ribose 5-phosphate is incredibly important because it's involved in nucleotide synthesis. Now that we understand exactly how NADPH is produced, now we can better examine cholesterol synthesis. So here is de novo cholesterol synthesis, and there's a lot of steps. However, I would recommend that you only pay attention to the very important parts of this. So here we have acetyl-CoA binding to acetyl-acetyl-CoA to produce HMG-CoA. HMG-CoA is acted on by the enzyme HMG-CoA reductase to produce mevalonate. Mevalonate is later converted into cholesterol. These enzymatic reactions require several additional molecules, most notably NADPH and ATP. So NADPH, which is produced from the HMP shunt, is very important in the biosynthetic pathway of cholesterol. And if we remember from our congenital adrenal hyperplasias or our defunct adrenal enzyme deficiencies, cholesterol is the precursor molecule to the hormones produced by the adrenal gland. And remember that these three layers represent the adrenal cortex, whereas the medulla produces catecholamines like norepinephrine and epinephrine. So now that we understand congenital adrenal hyperplasias, the HMP shunt, and cholesterol synthesis, let's go back to the vignette. A 2-week-old girl has poor feeding and lethargy. She was born with ambiguous genitalia, but normal female reproductive organs. Physical examination reveals bradycardia and a slightly depressed anterior fontanelle. Laboratory results reveal hyponatremia, hyperkalemia, and increased renin and 17-OH progesterone. A defect in steroid hormone synthesis is suspected. There's a lot to memorize about congenital adrenal deficiencies, but if you kind of pick the low-hanging fruit, it'll be easy to deduce which adrenal enzyme deficiency it is. There's only one adrenal enzyme deficiency, which causes hyperkalemia and hyponatremia, which is a physiological response to either a decrease in aldosterone or a decrease in 11-beta-corticosterone, which acts in the same way physiologically as aldosterone because it's involved in the pathway from cholesterol to aldosterone in the zona glomerulosa. So this patient is diagnosed with 21-hydroxylase deficiency because they are very transparent with us in saying this patient has a defect in steroid hormone synthesis. And if we remember, all steroid hormones produced by the adrenal gland come from the same precursor of cholesterol. And cholesterol requires NADPH produced from the HMP shunt and acetyl-CoA. Now, looking at this chart, we can see that NADPH, or F, is the correct answer. FAD, FADH2, NAD, NADH, and NAD+, are all involved in different biosynthetic reactions. Specifically, FAD, FADH2, NAD, and NADH are involved a lot in aerobic metabolism and aerobic respiration. and are not involved in cholesterol synthesis. NADP plus is involved in the HMP shunt, but it is not a cofactor in cholesterol synthesis. Thus, by process of elimination, NADPH is the correct answer.